My name is Anju Aggarwal, and I'm a family physician in Australia, Sydney. And tonight we'll have a very interesting session. It is about CT imaging in acute abdomen. It's in two parts, gastrointestinal tract and hepatobiliary system, and moderated by our Dr. Vinita Sharan. I'll briefly introduce Dr. Vinita Sharan and then head on with the session. So, as we all know, Dr. Vinita Sharan is a senior radiology consultant at DeepTek Medical Services. She is also adjunct faculty of Public Health Foundation of India. Vinita is former associate professor, Beda College of Medicine, Philippines. Dr. Vinita is advisor of radiology CMEs of GAPIO and very instrumental in organizing the virtual radiology sessions for GAPIO. I think this is your 13th session, if I'm right. They said 11th, but I think it's more than 11th.
I think in the old introduction.
Yeah. It might be your 13th and 14th session under your mentorship. Really appreciate Dr. Vinita. Thank you for that.
Thank you, Dr. Anju, for the kind introduction and your continued support for our radiology webinars. And I think I've been always relying on you to give us the opening remarks. So thank you so much for being there for us. And greetings of the day, everyone. Welcome to the Radiology International Lecture Series. This is the last for this year, and I hope we will come back next year with more interesting topics. And today we have a very important and very common issue, that is acute abdomen. It's a common issue, but it's very important. And we have two eminent speakers who will enlighten us on the radiological findings, the CT findings in acute abdomen. And to chair this session, we have Dr. Arun Prasad, who is a very renowned laparoscopic surgeon. And he will be also enlightening us on some of the surgical aspects of acute abdomen. So he did his graduation in Armed Forces Medical College, Pune, and master's from Maulana Azad Medical Center, New Delhi. And after that, he did his FRCS from London in 1990, and he was working at the Charing Cross Medical School and associated hospitals. And I think they started the laparoscopic surgery in that hospital. And on his return to India from UK in 1996, he joined Apollo as one of the youngest senior consultants. He was also conferred the prestigious Fellow of American College of Surgeons, USA, in 2019. And currently, he is the clinical lead and senior consultant in GI, Bariatric, and Robotic surgeries at Apollo Hospital, New Delhi. He has experience of performing more than 10,000 laparoscopic surgeries. And he is editor of Journal of Minimal Access Surgery, World Journal of Gastroenterology, and a reviewer for surgical endoscopy and obesity surgery. He's also a board member of EC Journal of Gastroenterology. And Dr. Arun Prasad is former president of Obesity Surgery Society of India and current president of International MGP OAGP Club of Bariatric Surgery. Sir, I had to find out what does MGP and OAGP mean. And he is also the current vice president of ARIS. And he has published more than 55 papers in various journals. So I now invite Dr. Arun Prasad to chair the session and also to introduce our eminent radiologists today.
Thank you. Thank you very much for those kind words. And thank you for inviting me to this meeting. I'm quite excited also as a delegate at this meeting to learn from what our prestigious and learned friends are going to talk about today. So we all know now that in the current era, a CT scan has become very important. When I was an MBBS student, it wasn't that crucial. In fact, it started developing when I was doing my post graduation. But today, a CT scan plays a crucial role in diagnosing and managing acute abdomen. This is a term that refers to sudden severe abdominal pain that may require urgent medical or surgical intervention. So, when we talk about acute abdomen, the rapid, detailed, and accurate insights that a CT scan can give, it helps in timely management of the patient, and it also improves the outcomes of our treatment. So it's really very important. So accurate diagnosis, rapid decision making, it minimizes diagnostic uncertainty. So if we've got lots of differential diagnosis, CT scan definitely helps us in coming to a conclusion, and it also guides our intervention. It helps us plan surgeries or image guided procedures. So in acute abdomen, as a surgeon, I have seen a lot of indications of inflammatory condition like appendix, diverticular disease, pancreatitis, bowel obstruction, ischemic bowel disease, perforation, even vascular conditions like aortic aneurysm, vascular ischemia. Then its importance is also there in trauma. So patients who are stable, no, not the ones who are hemodynamically unstable, but those who are hemodynamically stable, we get a lot of information, especially the solid organ injuries. And also my colleagues in gynecology and urology take a lot of help with CT scan for kidney stone, ovaries, cancer related causes. So it is really something of a great use. There are, of course, some limitations and contraindications, which I will leave it to our speakers today. And with those words, let me invite our first speaker, who is Dr. Asutosh Sahu, who is a fellow in emergency trauma and acute care at University of Toronto. He pursued advanced training in neuroimaging at King's College London, and he joined Boston Children's Hospital, Howard Medical School for fellowship. Subsequently, he has clinical expertise, which is further strengthened by a robust research portfolio with several peer-reviewed publications, numerous conference presentations, and ongoing research project. And he's currently the assistant professor in Department of Radiology at University of Michigan Medical School. And welcome, Dr. Asutosh. We also look forward to you joining GAPIO, but over to you for the talk.
Thank you, Dr. Prasad, for your kind introduction. And I just wanted to say that I'm currently a fellow at the University of Toronto, and in the subsequent year, I am going to join the University of Michigan as assistant professor in radiology. So let's get started with the today's session. I will be just in the screen share. All right. I hope the screen is visible to everybody.
Yeah, we can see.
Okay. So today we are going to talk about the CT imaging of acute abdomen in the gastrointestinal, all the emergencies that we will talk. So I will briefly talk about the stomach, small bowel, large bowel, and other conditions that lead to acute abdomen. So in the stomach, we can see gastritis, gastric ulcers, gastric volvulus, gastric pneumatosis, something related to trauma. And in small bowel obstruction, one of the most common thing, followed by intussusception, so gallstone ileus, hernias, diverticulum. And in the large bowel, again, we see one of the most common is acute appendicitis, followed by the its complications, many diverticulitis, cecal volvulus, bleeding from large bowel, such as angiodysplasia, and other subject we will touch like epithelial appendicitis, mesenteric paniculitis, ischemic bowel, and iatrogenic causes. So, starting with the topic, like what are the standard contrast protocols we use for any CT study? We first we must give oral and IV contrast. So oral contrast is usually either water, Omnipaque, or Volumen, and in the IV contrast we use around 100 to 120 cc of Omnipaque or Visipac, and we give at a certain injection rate, and this is very useful to delineate the different organs. And we usually use the protocol like arterial phase, venous phase, and non-contrast imaging. Arterial phase is very important to see the perfusion status of the organ. Venous phase is for better delineation of the parenchyma organs, and non-contrast is usually done when there is some contraindication to contrast, or we are just doing a KUB study to see the stones. And there are various advanced techniques in CT angiography, and we always use these tools to better appreciate the pathology. And oral contrast, and this is one of the important things, like I want to highlight, like oral contrast is very useful even in the emergency settings. Like there is sometimes it is thought that the oral contrast lead to delay in diagnosis because the patient has to drink the oral contrast and wait for some time. But usually the quality of the study improves, and depending on the context, it's always useful to use the oral contrast in emergency CTs. And contrast enhanced CTs are always better than non-contrast CTs, and because the non-contrast CTs, the recent article from JAMA, they say that on an non-enhanced CT is about 30% less accurate than contrast enhanced CT. So we must always try to use the contrast CTs wherever possible. And we can miss some pathologies in the CT scan. For example, when there is inadequate oral or IV contrast, or there is incorrect acquisition phases, or when there is limited imaging phases, or sometimes we miss it. So we must be careful about these things. And how we optimize the protocols. So we should always use the proper distension, and sometimes there can be motion artifact leading to some missing of pathology, and sometimes the incomplete history. That is also one of the reasons that we are not sure what to look for. And and when we are imaging the stomach, we must use the negative oral contrast to achieve adequate gastric distance. So now coming to the cases, we will be doing a number of case reviews. At around 40 to 50 cases we will be reviewing today to see what are the different pathologies that we encounter in the acute abdomen. So this is the first case, a 75-year-old woman with nausea and vomiting. And we see this is the stomach. This is hugely distended. The mucosa appears enhanced. There is mucosal enhancement that we see here, and the submucosal edema is there. So this is a case of infectious gastritis. So around 5% of cases in emergency ward, they come with abdomen pain who have some gastritis. And if there is severe gastritis, we will see this kind of picture, the focal wall thickening. And one of the main differences for this is gastric neoplasm. So again, endoscopy sometimes is necessary to exclude whether this gastritis is, we are not missing out any tumor. Another case, 56-year-old woman with nausea and vomiting. Here we see a small gastric ulcer here. This is a small ulcer. We can see there is a breach in the mucosa of the gastric wall, and you can clearly see here. So this is a non-perforated gastric ulcer. Again, this is a common cause of pain in the abdomen. And again, one of the major differential is tumors, and we must always do endoscopy to rule out any malignancy in these cases. This is again 52-year-old man who comes with acute abdominal pain, and this is the CT showing there is free air under the diaphragm, and this ulcer has actually perforated. This is a gastric ulcer. The previous one was not perforated, but this gastric ulcer has perforated, leading to pneumoperitoneum and leakage of gastric juice into the peritoneum. This is a 67-year-old man who came with acute nausea. So what we see here is this is a case of volvulus. The stomach has tilted. The stomach has flipped against its own axis. The organoaxial volvulus is the kind of organoaxial volvulus where the stomach rotates around its long axis. So this is the lesser curvature and the greater curvature. They are on the opposite side. So again, this is an acute emergency, and the patient usually presents with sudden epigastric pain, with retching and inability to pass the NG tube. And CT has a very important role in diagnosing the volvulus. Another type of volvulus is the previous one was organoaxial volvulus, and this kind of volvulus is called mesenteroaxial volvulus. This is rarer compared to the organoaxial volvulus, and here we see like the stomach rotates against its own short axis. So this is the fundus of the stomach, and this is the body, and this is the duodenum. So this the stomach has tilted and flipped position with respect to the antrum. Antrum is superiorly placed. This is another case of acute abdomen. This patient presented with acute nausea and vomiting. So here we see the stomach. There is lots of small air bubbles in the wall of the stomach. So this is called pneumatosis. So there is a perforating ulcer, and from the inferior stomach fundus, and the air is escaping here into the lesser sac. So again, this is leading to secondary pneumoperitoneum. So this is called gastric pneumatosis, and and this can result from infection or any ischemia or some aortic procedures like endoscopy or some caustic injuries. This is a case after RTA. So this is a case. This is showing this is the stomach. This is showing the hyperdensity here. So this is a mural hematoma. This is again one of the common presentation in trauma. So there is local fat stranding is there, and focal wall thickening is there, and there is a gastric rupture, and there is hematoma formation. So this is somehow rare. And this is a case of a 48-year-old woman, acute nausea followed by initiation of prednisone for sciatica. So the patient was taking prednisone for some time, and then she presented with pain abdomen. And when we see again, there is gastric wall thickening here. So this is chemical gastritis. The first case we saw was infectious gastritis, and this one is chemical gastritis. In both the cases, the presentation is similar, and the imaging is also similar. The only crucial thing is we must exclude any tumors, underlying tumors, if possible, by endoscopy. Next, we come to small bowel obstruction. So small bowel obstruction, this is again 20% case of acute abdomen, and so CT has a very important role in diagnosing small bowel obstruction. So we determine the site where it is obstructed, whether there is any strangulation or whether there is any ischemia is there. So the CT signs of bowel obstruction are like the bowel will be dilated, like we see here. It will be at least more than 2.5 centimeter, and the wall will be thickened, and the wall will show enhancement, either increased or decreased, depending on whether it is ischemia or inflammation. And there will be abnormal positioning of the bowel, depending on hernia or malrotation. And the small bowel feces sign, that is a very important sign. So when there is a small bowel obstruction, the food material, the transit becomes very slow. So that leads to stool-like material formation in the small bowel. So that is an important thing that helps in identifying the transition zone, like where the small bowel has obstructed. So it is usually difficult to find out exactly what is the site so that the surgeon can open the abdomen and fix it. But it's very important for us to tell the surgeon that, see, this is the site which we think most probably has a adhesive band or something. So this small bowel feces sign, this helps in identifying that potential site of obstruction. So again, this is you can see the distended small bowel loops, and this is the small bowel feces sign. And next we see here, this is the site of obstruction. So this is the small bowel feces sign, and there was some adhesion. So that lead to obstruction. And we can also see there is mucosal hyperenhancement, the vascular prominence in the mesenteric vessel prominence. So this is again very important in the small bowel obstruction cases. So Crohn's disease is one of the major causes of bowel obstruction. So here CT angiography plays an important role, like mucosal hyperenhancement, we can see, the wall thickening, we can see, mural stratification, we will see, and there is a calm sign, like the enhanced small vessels near the bowel. We will come to all the features. So here, so there is a small bowel thickening due to Crohn's. So here we see the small bowel appears very thickened. And here again, we see the small bowel appears thickened and the wall is hyper-enhancing. So this is the case of Crohn's. So this is the small bowel, there's this kind of stricture formation is there. And this is called the Coombs sign, where there is mucosal hyper-enhancement and we see a lot of small vessels going towards the small bowel. And this is another case of Crohn's disease, patient presented with abdomen pain, and there is diffuse wall thickening of the small bowel. Again, we see very diffuse wall thickening. Again, this is the extensive small bowel thickening we see. So this is a classical presentation of Crohn's disease, extensive Crohn's disease. Again, similar, same patient, multiple. And Crohn's disease can also lead to duodenal strictures. Here we see a small stricture. This is the proximal and the distal duodenum, and we see the stricture, and here another stricture. So again, this is the stricture is leading to the obstruction of the duodenum, and this leads to dilatation of the bowel as well. Some other causes of in small bowel obstruction can be intersusception, like jejuno-ileal intersusception, where one loop of a bowel gets inside another loop of bowel. So maybe due to some underlying tumor or a lipoma or some lymph node. So one loop of bowel gets inside another loop of bowel that leads to the intersusception. Sometimes gallstone ileus can also present with small bowel obstruction. So the patient had a gallstone and this has come down to the ileum, distal ileum, and it has obstructed. So this leads to bowel dilatation. And sometimes closed loop obstruction also is possible, where the mesentery twists around itself. And there is the prominent converging mesenteric vessels that we see here. This is the localized vessels, they are converging on it. Then, then there can be bowel wall thickening and mural hypertensity. Again, all these features are small bowel obstructions. Sometimes incarcerated hernia, the inguinoscrotal hernia. So here is the patient's left scrotum and the small bowel has entered inside it, and then that has got twisted along the mesentery, and that we can see all the fat stranding here. So that suggests that there is some incarceration, there is some inflammation or ischemia going on, and the proximal bowel loops have all dilated. Now we will come to the large bowel and acute appendicitis, one of the most common surgical causes of acute abdomen that is not caused by trauma, and it is top 5 conditions presenting with the emergency department. And CT is excellent choice to rule out acute appendicitis. So with CT, we can decrease the negative predictive value from 26% to 5%. So here, so the major CT criteria for diagnosis is more than 6 millimeter dilatation of the appendix, and there is thickening and periappendiceal inflammation will be there, and sometimes we will see an appendicolith. Here again we see the distended appendix fluid filled, and sometimes in this case, even with non-contrast CT, we can confidently diagnose acute appendicitis. And here again, so sometimes what happens, the appendix is dilated more than 6 millimeter. However, there is no periappendiceal inflammation. So in this case, there is another criteria, like the intraluminal, the thickness, the intraluminal diameter of the appendix. If it is more than 2.6 millimeter, then this can be also useful criteria to differentiate the appendicitis from the normal appendix in the absence of periappendiceal inflammation. Sometimes the appendicitis can happen at the tip. Like here is the distal part only of the appendix that is inflamed. The proximal part is normal. So that's why we must see whole of appendix to rule out appendicitis. And sometimes there can be stump appendicitis. So when we do a laparoscopic removal of the appendix, the stump remains, and sometimes the appendicitis can happen in the stump. So radiologists should always look for stump appendicitis, even if there is a history of appendicitis. There can be appendicitis without it. So this is again a perforated appendicitis and leading to abscess formation. Mucosal of appendix, this is again an important surgical condition. So there is abnormal mucus accumulation leading to the appendix becoming hugely distended here. So the diameter becomes more than 1.3 centimeter. And if we do a laparoscopic approach, then there is a high risk of perforation, and this can lead to pseudomyxoma peritoni in this case. Now we will come to another condition, epiploic appendicitis. So the epiploic appendicitis is the overt fat attenuation lesion. So this is on the surface of the colon. So in the surface of the colon, we see the appendicitis. So this can get inflamed, and this can mimic acute appendicitis. So, but there is only inflammation in the fat adjacent to the colon. Sometimes we see omental infarctions. So this is a solitary heterogeneous fatty mass we can see anterior to the colon and just below the anterior abdominal wall. So here we see there is increased fat attenuation compared to the rest of the omentum. So this is called omental infarction. So this is self-limiting, nothing to be done. So just conservative management. This is a mesenteric panniculitis. Again, the mesentery, some vascular insult is there. So that's the inflammatory process. Again, this is also self-limiting. So this is a key table summarizing the three conditions: epiploic appendicitis, infarction, and pancreatitis. Now, diverticulitis of the bowel is, again, this is another important condition. This can lead to acute abdomen, and small bowel and large bowel diverticula are there, but most common is the sigmoid colon. That is the most site of diverticulitis. So here we see the adjacent to the sigmoid colon, there is pericolonic fat stranding is there. Some focal mural thickening is there. And this is called centipede sign, where the vasa recta that feeds the colon that gets engorged. So there can be multiple complications of diverticulitis. So this can perforate. Here we see some air densities. That's the perforation. That can lead to pneumoperitoneum. That can also lead to intramural abscess formation. The inframesenteric vein that can get thrombosed, so that can lead to thrombophlebitis. The diverticulitis also can lead to retroperitoneal abscess. It can fistulize with the urinary bladder, lead to colovesical fistula, as we see here, the air densities, and here is the diverticula, which has fistulized, leading to air densities here. And this can also lead to hemorrhage. Diverticular, one of the main complications. And Meckel's diverticulitis, this is a congenital condition. So if it is there, it will bleed here, and it will lead to recurrent pain episodes in childhood and subsequent life. And cecal diverticulitis, this is again important because this requires aggressive surgical management, because it has a high likelihood of recurrence. It's not surgically corrected. And cecal volvulus is another condition that can lead to acute abdomen. So the cecum appears hugely dilated, and it looks like a coma bean shaped. Next, we will come to the ischemic bowel disease. This is again very important condition leading to acute abdomen. So we see luminal dilatation, we will see bowel wall thickening, we'll see the dilated mesenteric veins, we'll see edema and the gas. We'll all see all the imaging pictures shortly. So ischemia, why this ischemia happens? Like the supramesenteric artery or the celiac artery, they are the main feeders of the small bowel and large bowel. So gradually with age, there can be development of plaques. And sometimes the plaques become so big that they completely occlude the vessel. So here we see the SMA, the supramesenteric artery, has occluded. This has completely occluded. So the patient presented with acute abdomen, decreased bowel sounds, and abdomen pain. So here we see that this is all dilated bowel. This is a contrast enhanced CT, but the bowel is not getting enhanced. And we also see some small pneumatosis, that is the air densities in the bowel. So this suggests that due to the lack of vascular supply, this has infarcted. Again, we see here clearly the supramesenteric artery thrombus, and this is after surgery, this has been corrected. And here again, we see the supramesenteric artery thrombus, and this is the bowel that has been thickened. There is pericolic edema, there is fat stranding. And the SMA clot, it is always crucial to look for SMA. But here, this is the aorta, this is the SMA. But in this cut, we don't see any thrombus in the SMA. But when we go down a bit, then here we see there is the thrombus. So it is always important to see the entire extent of the SMA, because sometimes in the proximally, we may not find a thrombus here or any occlusion, but the SMA might have a thrombus in the distal aspect. So as we see here, the proximal SMA is clear, but there is a thrombus in the distal SMA. So it is very important to look for the whole of the SMA to explain a thrombus. And there can be ischemic bowel with clot in the portal vein or supramesenteric vein. So this is the supramesenteric vein, and this is the portal vein. So there is the thrombus, and that can also lead to bowel ischemia because the venous return will be compromised. And here again, we see the congestive bowel, and this is a thrombus here. And sometimes the celiac vessels can be narrow, that can lead to also, as we see here. And the ischemic small bowel also can get very much dilated with, and this can lead to pneumatosis, like the bowel gets infarcted extensively, and all these air densities are there in the bowel wall, and they can ultimately go to the portal vein, the mesenteric vein, to the portal vein, into the hepatic veins, and as we see here, biliary, the pneumobilia is there, or the biliary radicals, they have all filled with air, and this is a very bad prognostic sign because there is extensive infarction of the bowel, and that lead to the extensive pneumobilia. Colitis, again, a very common differential of colonic wall thickening, but again, one of the important thing is to exclude any kind of tumor because there is segmental wall thickening, and appropriate clinical context, we must exclude any kind of tumor, even if we see in the emergency setting. Later, after the inflammation subsides, we must exclude. And we'll finish our talk with the iatrogenic contribution to the small bowel pathology. So the inflammation can also happen with the bone marrow transplant or chemotherapy or radiation therapy, or sometimes ACE inhibitors. We will see with the examples. So this is a graft versus host disease of a patient with myeloma and post bone marrow transplant. You see the small bowel have been diffusely inflamed. Again, this is mucosal hyperemia. We can see the mucosal wall is very much hyperemic, this bright mucosal wall. Again, we see here mucosa appears very hyper-enhancing. And again, chemotherapy-induced enteritis is also possible. So the presentation is always similar. So we must get the appropriate clinical history from the patient, whether the patient has recently chemotherapy or the patient, this is again chemotherapy-induced enteritis in the CA pancreas. And that can also lead to pneumatosis intestinalis, as we see the air densities in the bowel wall. And also with radiation as well, we can get a similar picture. There can be rectal wall thickening, there can be fat stranding. Like this, we see this wall thickening and the stranding and the mucosal hyperenhancement here. So again, radiation enteritis has similar picture to any kind of enteritis. The only thing is we must have the proper clinical history to differentiate these conditions. And sometimes the ACE inhibitor like lisinopril, captopril. So sometimes patient starts the drug and they can develop angioedema, and this will lead to bowel wall thickening. So just like they have facial puffiness, respiratory distress, they can also have small bowel thickening and edema. ACE inhibitors. And we will finish our talk with the GI bleeding of the colon. So there are inflammatory conditions, ischemic conditions, cancers, and radiation chemotherapy. All these lead to GI bleeding. So I will briefly say how we differentiate the bleed and how best we can appreciate the bleed. So angiodysplasia is one of the major causes of GI bleeding, and mostly it is in the right side of colon. And colonoscopy in this case is not usually very sensitive, and that's why CT angiography is very much accurate. So here we see in the CT angiography, this is a ascending colon. We see multiple vascular submixer tufts visible in the wall of the colon. And when we do the MPR, image reconstruction, so we can see the densely opacified dilated draining veins and early filling veins and the dilated feeding artery. They are very much appreciated in this reconstructed image. So sometimes the diverticular bleed can be missed in the arterial veins. Here we see a small diverticular bleed in the arterial veins, but sometimes it can be missed. So we should always do a venous phase imaging. So here we see the arterial phase imaging, we see a small bleed, but when we do a 60-second delayed venous phase imaging, there is significant blood accumulation here. So this is very useful. That's why we must always do a venous phase imaging and look for the increase in the size of the bleed. Then this suggests that there is active extravasation and active bleed happening. So again, here is the example. This is the arterial phase, and this is the venous phase. We can see significant increase in the bleed. So this is ongoing bleeding happening in the patient. And sometimes there can be rectal bleed. The patient comes with some bleeding per rectum, but we do a angio and it is negative. So as we see here, this is the rectum, the distended, and there is some small amount of hyperdense fluid is there. So here we see some small layering hyperdense fluid, but this can be missed. This we may not be confident what is happening. So when we do a arterial phase and followed by venous phase imaging, we can see the blood pooling, active blood pooling into the rectum, and this suggests that there is a venous phase. That this shows the importance of the venous phase imaging in any case of GI bleed. So I conclude my talk with this. CT is the preferred imaging study to a wide range of small and large bowel pathologies, and that's why we must utilize CT to improve the patient care and for rapid and accurate decision making. And if effectiveness of CT can be limited by insufficient clinical history, like I said, that sometimes the chemotherapy and radiation-induced enteritis can mimic some infectious or inflammatory conditions. So we must always have a proper clinical history, and that's how we can support and get a better diagnosis and improve the patient care. Thank you.
Yeah, I think Dr. Arun Prasad is, I think he's muted.
Yes.
Yeah, okay.
Okay, thank you. So we'll probably take the questions at the end. And I will now invite our second speaker. That's Dr. Mukesh Harisinghani. He is a professor of radiology at Harvard Medical School and director of abdominal MRI and clinical discovery program at Massachusetts General Hospital in Boston. Also, he is the section editor for the GU Radiology for the American Journal of Radiology. He has research interests which include MRI applications in body imaging, genitourinary radiology, and translational molecular imaging. I have no clue on what translational molecular imaging means, but I look forward to his talk on this. He is involved in the development and application of novel molecular biomarkers imaged by MRI. He has concluded translational clinical trial for use of magnetic nanoparticles for use in cancer detection and staging. That really sounds very impressive. His clinical expertise is in MR applications within the abdomen and pelvis. He has authored or co-authored over 150 scientific papers and edited 5 books in these areas. So welcome, Dr. Mukesh Harisinghani, and over to you for your presentation. We look forward to your talk.
Thank you, Dr. Prasad, for the kind introduction, and also would like to thank Dr. Vinita for the kind invitation. Just wanted to make sure if someone could just say if they can see my screen.
Yeah,
and
yeah,
perfect.
we can see your screen.
Yes, we can see.
Perfect, thank you. So continuing along the scheme, or what has been nicely summarized by Dr. Asutosh, in terms of looking at how does CT add value, I think what I'm going to do in the next 20 minutes is look at or show you some key cases where I want to emphasize basically 2 or 3 points. One is clinical context is very important for us as radiologists. We cannot read the exam in vacuum when no information is provided to us. And sometimes it's incumbent on us to, dig into the patient's chart. And what my mentor used to say, you have to always biopsy the chart first before you actually start looking at the scan, in order to see what kind of surgery the patient has had or what's the relevant prior history that we need to pay attention to. And then the next thing to keep in mind is sometimes, things that present acutely are not necessarily acute conditions. So those are some key points that I'll, communicate. It's difficult to cover the entire gamut, but I'm hoping with these few cases, there are some take-home points that the audience can, take with them and also help them understand what hepatobiliary acute conditions can look like on CT. So with that, we'll start with the first patient. This is a 55-year-old male who presents with abdominal pain every time he eats. And this has been going on for a few months, and all of a sudden became a little more severe. So that's why I decided to come to the emergency room. And I'm going to show the axial CT study. And as you can see, this is done with IV contrast. You can see the vessels are opacified, the kidneys are enhanced. And as I scroll through, the liver looks pretty unremarkable. There is no intrahepatic ductal or biliary ductal dilatation. But when one comes to the region of the porta, you can see that this structure that you see is a dilated common bile duct. Now, this is very markedly dilated. This is not what the normal size of the bile duct ought to be. But despite the dilatation, you can see there is relatively no intrahepatic ductal dilatation. And this will become relevant to what the disease entity we are talking about. The other interesting thing is if you look inside the duct, you expect to see fluid density because bile is fluid density, and that should be like this as the gallbladder, bile in the gallbladder looks like. But as you can see, there is, it's not as homogeneous, low density as you see here. There are bright areas within the lumen itself right here as well. And this is the pancreatic head, and you can see the bile duct is in that location, the same thing. And then it gradually tapers down to what you would expect a normal caliber to be. And so that's what it's seeing on the axial. Now, I'll show the same finding in the coronal. And that is another important point to emphasize is that we never look at anatomy in real time in one plane. You always have to look at multiple planes. That helps you narrow down the, or gives you a clue on the diagnosis. So this is, again, the gallbladder right here. We are seeing the liver. Again, pertinent negative is there is no intrahepatic biliary ductal dilatation, which is relevant. And as we come to the gallbladder, you can see this is sort of the point of the cystic duct. This is the portal vein right here. And similarly, as we saw in the axial image, this is the massively dilated segment of bile duct, which has internal, some kind of debris, which you see is bright and looks brighter. And what is interesting is right here, you can see the nice change in caliber. Now, when you see an abrupt caliber change like this, one of the things you always worry about is, am I dealing with some kind of a mass lesion that is either extrinsic or intrinsic to the duct, which is causing this narrowing? And one doesn't see anything to that effect. Moreover, if you could imagine, just like in plumbing, if you have an obstruction to the bile duct, and if there was dilatation more proximally, it should also cause intrahepatic biliary ductal dilatation, which is not happening here. So in summary, what you're seeing here is there is a focal dilatation of the common bile duct. There is internal, what looks like debris or, bright stones within that dilated segment. We don't see any mass lesion causing the dilatation, and there is relevant lack of dilatation of the intrahepatic bile ducts. And given the symptoms that the patient is facing, every time the patient eats, he gets an acute pain. If you bring all that together, the question is, what is the diagnosis? So let's go through. So where is the abnormality and what is the diagnosis? Now, we had a good inclination on what it was. And I know it's a CT talk, but I'm going to show you some other modality as well. In this case, an MR was done just to confirm. And it kind of confirms nicely what we saw on CT. No intrahepatic bile duct dilatation. This is the normal appearing gallbladder. And as you can see, this is the focally dilated segment of the bile duct, which has these dark stones within it. And this is the change in caliber with no mass lesion that is seen either in the pancreas or within the bile duct. And this is just showing a different depiction of the same finding, the gallbladder, the common bile duct, the filling defects in the bile duct, the change in caliber, no mass lesion there, and relative lack of intrahepatic ductal dilatation. And that's what it looks like on on the MEP images. And so when you see that combination, that's the symptomatology that the patient presented with, focal dilatation, filling defects. So this is a classic finding of what we describe as a choledochal cyst to be. And as we all know, there are 5 different varieties of Todani classification, the most common being the type 1, which was seen in this case. There was a focal fusiform dilatation of the bile duct, which we saw, with relatively preserved intrahepatic bile ducts, no mass lesion seen. And then there are other variants where you can get a choledococele, or you can see distal dilatation, a fusiform dilatation or choledococele in type 3, and then you can have intra and extrahepatic bile ducts involved. So various fine, but I think the most common type, most common type is the type 1, and this was actually surgically resected. And this is the path report. A patient had chronic cholecystitis, which we didn't appreciate on CT, but there was a type 1 choledochal cyst with the intrahepatic bile duct stone. So again, a classic finding. Now we move on to the next case. This is a 44-year-old male patient who presents with right upper quadrant pain, jaundice, dark urine, and light stools. And so let's look at his scan. So let's start with the axial study. Now, in this patient, as you can see, this is also done with IV contrast. You can see the portal vein is enhanced. And right next to the portal vein, you shouldn't be seeing any bile ducts. What you're seeing is prominence or dilatation of the bile duct. So unlike the previous case, this patient has biliary ductal dilatation. As you can see, all these black or dark areas adjoining the portal vein are dilated bile ducts. And you can follow it all the way to the porta. As we come down, this is the right portal vein leading into the main portal vein. And when you come to the region of the porta, what you see is, so here is the gallbladder, and what you're seeing here is some kind of calcified material which is present in the cystic duct of the gallbladder. And so, again, multiple gallstones also seen. The gallbladder interface with the liver is pretty sharp. There isn't a lot of edema, if you will. And so that's sort of on the axial. Now let's look at the same thing on the coronal, or a different projection as we go through. So this is, again, you can start seeing the dilatation of the bile ducts in the liver, which means there is some downstream obstruction. And what you see here is a dilated gallbladder. This is the calcified stones in the cystic duct. And here's the main portal vein, and you can nicely see the dilatation of the common bile ducts. And so the question is, given the patient's symptom, young guy, 44 years of age, presents with jaundice, which is acute in presentation, the question is, what's going on? And so in this case, what you're seeing is there is intrahepatic bile duct dilatation, and it's coming up to the level of the porta. Again, when you see that, you always want to make sure there is no mass lesion, which we don't appreciate here. But what we do see is there are presence of gallstones, and there clearly are stones that are lodged in the cystic duct, which is right at the point where you see it enter into the common bile duct. So the most likely cause here is that these stones are causing blockage, or they are stuck in the area of the cystic duct, and that because they cause secondary inflammation as a result of them being impacted in that location, that inflammation secondarily causes obstruction of the common bile duct. And that is a syndrome that we typically see in acute setting that is called the Merizet's syndrome. And so that's what is, again, on the just highlighting on the coronal, that impacted calcified stone in the cystic duct, causing secondary narrowing of the common bile duct. And so this is a syndrome that is defined as common bile duct obstruction, which is secondary to a gallstone impaction in the cystic duct or in the infundibulum of the gallbladder. This impaction of the stone leads to edema that leads to mass effect of the adjacent common bile duct, and therefore you can see secondary obstructive changes in the intrahepatic bile ducts as well. And the classic way as this patient presented, they get jaundice, fever, and right upper quadrant pain. So that's sort of, now it's important to realize that this is the classic description as we are all taught. Now, what we may not be aware, as you can see in the surgical literature, the Merizet's syndrome also has a gamut, and there's actually a classification of what the findings on Merizet's syndrome can be. And so these are the 5 types. So type 1 is when there is obstruction of the extrahepatic duct because of stones that are lodged in the cystic duct, which was the case in this patient. Now, what ends up happening is gradually as the inflammation progresses, it starts eroding into the lumen of the common bile duct. So the type 2 and type 3 is basically, it's referred to as a cholecystodocal fistula. And the diameter is of that fistula is less than 1/3 the diameter of the common bile duct in type 2, and it's greater than 2/3 the diameter of the bile duct in type 3. And type 4 is when the cholecystodocal fistula, it's totally involving the wall of the duct and kind of erodes into. And type 5 is where you can have direct erosion. In addition to what you're seeing at the bile duct, there is also erosion of the gallbladder into the small bowel, and this can give rise to gallstone ileus or Bouvet syndrome, depending on where the stone lodges. So it's important. The take home is, from an imaging perspective, we are used to thinking about just Merit-C syndrome being just this specific type, but there are 5 different varieties, and as imagers, we have to be aware of these entities, of this classification. So moving on to the next case, this is a 40-year-old male status post subtotal lap cholecystectomy in 2014, so many years ago. Again, comes in with severe right upper quadrant pain. So let's look at the axial image on this patient. Oops, here we go. So as you can see in this case, these are the clips where the subtotal cholecystectomy was done. But what we see is downstream from there is a little bit of calcification. And then you see, normally the fat should be dark like this when it is not inflamed. But in this case, you clearly see that what we call as dirty fat or haziness that is present adjacent to that location where you're seeing this calcification. There is, again, no intrahepatic ductal dilatation on this axial. And so now let's look at the coronal. Same thing, you're seeing the clips, and then what you see is a sort of a low density area that is distended, and you're seeing calcification distally at that point. And you can see this is the cystic duct right here, as I'm pointing, that's making its way to the common bile duct, which is normal in caliber, and there is no intrahepatic ductal dilatation. So in this case, I think the history that was provided and the way the patient presented becomes very relevant. And first of all, I gave you the history that this patient had subtotal laparoscopic cholecystectomy. As imagers, we need to understand what that implies. Now, this Dr. Prasad is probably very familiar, and I'm sure the surgeons on the audience are, this Callett's triangle, which is formed by, which has these boundaries. And it's a common triangle that is, of relevance in surgical planning. Typically, when patients present with acute cholecystitis, sometimes there is a lot of inflammation that is present in this triangular area. And when that is the case and the patient is undergoing laparoscopic cholecystectomy, one may not be able to take out the entirety of the gallbladder. In that case, they may leave part of the gallbladder in. So it's kind of a bailout procedure. And that may happen if the surgeon is not able to adequately identify the anatomic structures, and also there is a risk of injury. And this sort of a Moynihan's hump, as we call in the right hepatic artery, would be one such indication, with a lot of inflammation surrounding it. So the bottom line is, because the surgeon is not comfortable in removing the entire gallbladder, they take out part of the gallbladder and leave part of the gallbladder in. And when that happens, what can happen is that that remainder of the gallbladder, just like the gallbladder that was resected, is susceptible to stone formation and inflammation. And so in this case, that was the case, and this patient underwent surgery. And at surgery, they found a 3 millimeter cystic duct stone and what was referred to as stump cholecystitis. Now, this is a term that is used when the gallbladder remnant becomes inflamed and they can get recurrent stones after subtotal cholecystectomy. It's about 5% incidence. Patient when you tell the patient, geez, you have a, stump cholecystitis, they get very upset because according to them, their gallbladder has been taken out. So again, something relevant to keep in mind when you look in the chart and it says subtotal cholecystectomy. Obviously, these patients require an open completion cholecystectomy, and which was the case in this specific patient, and he subsequently did well. So that's again, an important thing to keep in mind. Moving on to the next case, this is an 89-year-old woman with a history of aortic stenosis, partial Billroth-2 procedure, presents with an episode of dysphagia following eating sushi. So because she had dysphagia, they did an upper GI study with barium that showed tertiary contractions in the esophagus, but there was no mass lesion seen. Anyway, they ended up getting a CT scan. So let me just show you what the CT scan shows. So as we come down, what you see in this case is this is the common bile duct right here. This is the portal vein, and you can see there is a little bit of ductal dilatation, intrahepatic ductal dilatation. As we follow the common bile duct coming down into the pancreas, you see there is a dependent hyperdense area right here. In addition to that, if you look at the gallbladder itself, you can see that there are dependent high density foci within the gallbladder lumen. So that's what you see on axial. Now let's see the same thing on coronal. So this is her, bad looking aorta. This is the portal vein coming in. You can see here's the gallbladder. First, we'll kind of, here, there are these are the gallstones that are seen. Now let's focus on the common bile duct. And as we said, there was a little bit of intrahepatic ductal dilatation. We come into the region of the common bile duct, and you can clearly see that there is a hyperdense stone in the distal common bile duct. So the diagnosis here would be she clearly has cholelithiasis or gallstones, and she also has choledocholithiasis or stone in the common bile duct. And that probably is the cause of her symptoms. So that was the presumptive diagnosis that was provided on the CT study, cholelithiasis and choledocholithiasis. And there was some inflammation seen around the gallbladder. The question was, is that cholecystitis or not? But, they were not sure. Now, while she was in the emergency room, she was kept for observation. And during that time, she develops a slight fever. Now, obviously, patients who have common bile duct stones, then they develop fever. One thing that you're worried about is ascending cholangitis. And so that was the suspicion that she had cholangitis. So despite her age, they decided to do a endoscopic procedure, where they thought they would do a sphincterotomy and remove the common bile duct stone, and thereby relieving her of her symptoms as well as the obstruction. So these are some selected images from the ERCP. Now remember, she had a partial Billroth-2 that makes cannulation a little bit difficult, but they were able to successfully do that. The problem was they were not able to easily get to the bile duct and remove the stone. So the stone could not be extracted. So they ended up leaving a plastic stent, biliary stent in. So that was what was done, and that kind of brought her fever down. She felt symptomatically a little bit better, and she was told to go home and come back in a couple of days for a follow-up. She goes home. In about a day and a half, she develops severe right-sided upper quadrant pain, and now comes back to the emergency room and gets a repeat CT study. So this is where we started off, just to kind of show you the axial and coronal, and we'll focus on the gallbladder this time. You can see this is what the gallbladder looked like. Now let me show you the axial when she came back subsequently. You can see the plastic stent that has been placed. She still has some mild dilatation of the bile ducts, which is not unexpected. And as we come down, you can see the stent traverses the common bile duct. But look what has happened to the gallbladder in the 2 days. Now, compared to before, it is massively distended, which it was not early on. There is a lot free fluid that is present adjacent to the gallbladder in the right paracolic gutter. And what is also interesting is when you come to the region of the porta, there seems like, which was not the case before, some change in morphology and a little bit of thickening right there. And so let me now show you what it looks like on coronal, just so that you can get a so this is the coronal. Again, you can see there is a patient has developed ascites. This is the large distended gallbladder. And as again, here's the biliary stent, the plastic stent that was placed in the bile duct. You can see as we come to the gallbladder fundus, it looks like, there is a little bit of a twist going on there. Not the normal morphology of what you expect to be in the gallbladder. So rapid change in a matter of day and a half in somebody who had choledocholitis and a stent placed and has stone. So the question is, what has led to this, going from here, becoming the gallbladder becoming like this? And this is so dilated gallbladder with altered configuration of the neck compared to, which was concerning for torsion. That's the way it was read. The CT was read. And here is a surgical snippet. I'm just copying and pasting of what the surgeon saw. They did blunt dissection. Obviously, there were a lot of adhesions, and they had to lyse the adhesion to get to the infundibulum of the gallbladder. When they did go to the infundibulum, they identified the cystic duct and artery pedicle, which was clearly torsed. The duct was edematous and inflamed, and they had to carefully dissect along it. So this was a case of a gallbladder torsion. A torsion of the gallbladder is, again, a rare condition and can cause cholecystitis. It is an indication for urgent cholecystectomy. The problem is the diagnosis can be seldom made before surgery. In this case, we had the luxury of having the scan a day and a half prior, and the dramatic change and the change in the morphology was what was suggested. And these are the CT signs that we see: twisting of the cystic pedicle, change in position of the gallbladder, thickening of the gallbladder wall, and pericholecystic changes. And the wall can sometimes be, because you can get hemorrhage in the wall, be high attenuation, and that can be appreciated on CT. I think my time is up. I'll stop here, and I'm happy to answer any questions. And thank you very much for the kind invitation, and as well as I hope this was useful.
Yeah. I think Dr. Arun Prasad had to leave because of some emergency. So thank you, Dr. Sahu and Dr. Mukesh Harisinghani. This was really very, very interesting topic and very nice presentation of all the different cases and very enlightening. I mean, we generally don't see so many cases in these scenarios as much. So it was very nicely explained also. So that is very nice. Audience, if you have any question, then you can just raise your hand. We can hand over the mic to you. Otherwise, I would ask one question. I mean, the cases were so very clearly defined that doesn't need many questions on them. But these days, since artificial intelligence has become a big topic, is there any scope of that for CT abdomen or the acute abdomen scenario? Dr. Harisinghani, you would know better from the best there.
Yeah, no, I think it's a very interesting landscape. Is all I'll say. When Professor Hinton, who got the Nobel Prize for artificial intelligence, he was asked, and he said, in 5 years, this was 10 years ago, there will be no need for radiologists because artificial intelligence will read all the images, and yet we are still here. And Elon Musk said, that artificial intelligence will be driving our cars, and as you can see, our radiologists still go to work in their cars. So the problem is, in order for AI to work very effectively in the acute setting, you have to ask the correct kind of question and provide the correct kind of data. There is so much of heterogeneity in what we see in the acute setting that it is very difficult to come up with a single solution that may provide the necessary framework. Where it may help is, in today's era, where I'm sure it's the same in the Indian subcontinent, where we are burdened with a large volume of cases. And sometimes what ends up happening is those that require immediate attention fall lower on the list just because they were scanned later. And so there are intelligent algorithms that sniff through the patient's charts and can bring up those cases right to the top of the list so that you read them right away. I think that's a good way of implementing a solution. And the second way it can help is, appropriately scanning the patient with the correct protocol. As Dr. Asutosh nicely showed that depending on the clinical indication, sometimes the protocol has to be varied. Question is, do you use dual energy CT or do you use regular helical scan? Those are the kind of scenarios where I think AI may be helpful in deciding, based on looking at the patient's clinical story, what would be the ideal test to do. But from a interpretation perspective, I think we are far away. At least not in my setting.
Yeah, especially the cases that you showed. I think comparing the previous and the current study and following it logically, what would be the reason for having those, like something like a gallbladder distortion that you showed? That would be very hard to figure out on, I think, I believe AI. So, for Dr. Sahu, I have a question on when you said about the contrast imaging. Can you a bit enlighten a little more? Like there are contraindications when you would not give contrast for the GI imaging if there is acute abdomen, if you expecting a perforation or something. How do you manage that?
The most important contraindication is like any prior anaphylactic reaction. If the patient had in the history, like patient had a shock or something when he had prior contrast injections. Other than that, in acute setting, if there is a severe bowel obstruction, then we do not prefer giving the contrast because that might unnecessarily further delay the diagnosis. Like the patient will sit to have the contrast and we may have to wait for 1 more hour or 2 hours. So the contrast will pass, but there is already obstruction and there is no point in those cases to give further contrast. And I think other than that, contrast always helps in like the oral contrast. It always helps in giving a better picture of what is happening. And IV contrast, I would say it is always useful to give IV contrast whenever possible if there is no absolute contraindication.
Okay. Thank you very much for your answer. And
And I would like to add one thing, regarding the AI. Right now, I'm working on deep learning image reconstruction. So it is one of the product by the GE vendors. So the deep learning, how it helps to some extent is like we can get better image qualities with lesser dose of radiation. So in cases where there are routine follow-up imaging is done, the patient gets scanned every 6 months. So if we implement those algorithms, deep learning algorithms, then we can reduce the contrast and the radiation dose to the patient. And we can have similar or even better quality images. So this is one way we can use the artificial intelligence. So mostly, I would say that artificial intelligence is for us to use, not to get afraid of. Like this is there to make our lives easier and to make our patient's life easier.
Yeah, so basically it is more of algorithms than actually interpreting the images. So that's heartening to know that there's still work for radiologists against all the predicted work and predictions that radiologist jobs are going to be extinct. So nice to know that. Yeah. So thank you, Dr. Mukesh Harisinghani and Dr. Asutosh for very, very interesting and very detailed and very nice examples in your talk. And I'm sure the audience has benefited quite a lot. Thank you, Dr. Anju Aggarwal, again for giving us the opening remarks. That's very nice. And I think Dr. Jain is still here. I thought he is not here. Dr. Jain, would you like to?
Yeah, Dr. Vinita, I'm still here. Unfortunately, cannot switch on my camera because I'm just traveling. But anyway, was throughout the session, I was attending the session. So it's my pleasure to thank both the speakers, Dr. Asutosh and Dr. Mukesh, and also Dr. Anju Aggarwal, she has joined all the way from Australia at very odd hours as far as timings are concerned. So thank you, Dr. Anju. Also, Dr. Vinita had been instrumental in organizing the session, and also Dr. Arun Prasad, who has helped us in moderating and introducing the topic. Thanks to the backend team from GAPIO and the IT team for making this happen. So thank you everyone from GAPIO and from the Radiology Association. So over to you, Dr. Vinita, for
also thank you to the audience for joining us. And this is festive time. You took out time to be here, and it has been very enlightening. So I would now end the session. And thanks once again, Dr. Harisinghani and Dr. Sahu, for your very nice and well exemplified talks. Thank you.
Thank you.